That was such an interesting session because we talked more globally about HHV-6. You know, we think that the epidemiology might be shifting because transplant practices are shifting. We're now using more letermovir for CMV prophylaxis, which has led to a decrease in the broad spectrum antivirals that normally we would have given for preemptive therapy of CMV. So these all can kind of impact the HHV-6 epidemiology. Good news is that we're not seeing any increasing signals at this point. Another important aspect was that, you know, HHV-6 has been implicated in a lot of different manifestations, and now we have a solid level of evidence to kind of really support these associations. And I think the most important is the role of HHV-6 as a lung pathogen with the Nature Communication paper from the Fred Hatch, the Seattle group that came out that showed that we could even have cutoffs that are associated with increased mortality or, you know, the risk of lytic infection. We also discussed about viral kinetics and how difficult it is to have a viral threshold above which to worry about encephalitis. Spoiler alert, where we do not think that we should be having a cutoff, a specific cutoff. Is more, you know, the general clinical context that should guide us. And then finally, we talked a little bit about the challenges in diagnosis. And we know that we have inherited chromosomal integration, which is kind of a very rare and unique condition that we see with HHV-6, but which leads to very high viral loads without having disease. So this is not something that requires treatment, but very often it confounds diagnosis. So it was very interesting to talk about the algorithm, how to approach that part. And I think that in the future, we will probably be able to have more widely accessible and standardized diagnostic tools to be able to tell apart reactivation from integration, which is not the case yet. Yeah, so lots of interesting stuff and discussions about how to diagnose and treat and even try to prevent HHV-6.